Welcome everybody again. Let's continue with upper extremity. We're going to be talking a little bit about forearm, but the muscles, a little bit of the innervation of those muscles. Remember, there are two compartments, anterior and posterior. The anterior compartment, by the way, happens to be a flexor and pronator action. And the dorsal compartment, and these flexors attach on the medial epicondyle. Common tendon, therefore, and there are going to be some on top of it on the ridge. On the lateral side, also a common tendon and some on the ridge, supracondylar ridge, but also they're going to be for the extensor compartment, they're going to be a specific motion as for extension and supination. So if you remember, flexion, pronation is going to be medial, extension, supination for lateral is going to help a lot if you think about the nerves that are also going to be innervating these structures. We're going to be talking a little bit about the hand and the wrist. So the wrist, understand that there are two rows, a proximal row and a distal row. The proximal row for bones, the distal row for bones. Try to think in a way, how can you organize this in your mind? For me, from the radial side, or where the thumb is, that's a scaphoid. On the proximal row, the lunate, the triquetrum, and the pisiform. For the distal row, the trapezium and the trapezoid. Then you're going to have, or the greater or lesser multangular, you're going to have the capitate. That has to do with the third metacarpal, capitate, and lunate. They have to go into the most medial side of the radius as the one axis, or one medial axis, or median axis of the hand and wrist. Then you're going to have after the capitate, you're going to have the hamate that has a hook that is very important for some specific conditions as the attachment of the carpal tunnel. So the proximal row, like I already said, in colors, you have them there: scaphoid, lunate, triquetrum, and pisiform. And the lunate, even though this is a diagram, just think about it should be a little bit more on this side with alignment with a capitate at the third metacarpal. The pisiform, typically you won't see it, even though you see it here, but then this is probably a palmar view. If you see the dorsal view, this bone is not seen because it's more volar or more palmar. Then the distal row, the trapezium or greater multangular, the trapezoid or lesser multangular, the capitate, and the hamate. The scaphoid holds two specific importance or relevant things. One, talking about the specific areas of the scaphoid as having a body, a waist, a tubercle. The thing that the waist happens is where the scaphoid has only one single artery that goes there. So when a fracture happens at this area, that only vessel, that only artery that comes from the radial artery as a branch, will probably cause necrosis, and a vascular necrosis, or won't allow to heal at this area. Any fracture on the distal end typically will heal normally or good because that artery won't be severed. But the proximal one typically is going to have a problem. Now the other thing important about the scaphoid is to understand that holds, if you see it from the lateral view or the sagittal view, holds more of an oblique type of presence, not the alignment being with the radius into the metacarpal, but has an oblique, like a 45-degree to 50-degree inclination from dorsal to volar. So you can feel it here too, the tubercle, this tubercle, you can feel it on the volar side, and that's important also for the carpal tunnel attachment. The trapezium has a tubercle, or the greater multangular, but also has a groove for the flexor carpi radialis, so attachment, that's important. The hamate has a hamulus, which is part of a hook that you can also feel it. So the tubercle of the scaphoid and the hook of the hammock become now important and relevant for the carpal tunnel. Now the only other thing, like I said, the capitate typically has to be in good alignment with the third metacarpal and the lunate with a radius for the central part of the axis of the hand and wrist. A dorsal view of this, and like I told you, you have your scaphoid, your lunate, you have your triquetrum, but you don't see the pisiform because it's underneath, it's volar. And the palmar view, now you can see the pisiform there. On the, looking at the first metacarpal and proximal to distal view, is how you're going to see the hook of the hamate and the pisiform. And these two structures are going to become important now for Guyon's canal. Guyon's canal, remember, that's where the neurovascular bundle of the ulnar or the ulnar neurovascular bundle are going. So these structures are important along with the scaphoid for the carpal tunnel at this area, as you can see it there. The other important thing about the trapezium is that the first CMC joint is statistically speaking, is the one that for osteoarthrosis is the first and the most common place to get arthrosis is the first one. So you're going to see a lot of surgeries and pathologies of the first CMC, the carpal metacarpal joint. So the skeleton of the hand, how they look like from metacarpal to the proximal, middle, and distal phalanx. And just remember that the thumb doesn't carry 3 phalanges, just 2. The others do carry 3 and 5 metacarpals. The other important thing and relevance when looking at this, if you see this image, you're going to see always that the ulnar styloid is not as high or as distal as the radial. So you're always going to have kind of a pitch there, a difference in angle. And this is relevant when you happen to have fracture or dislocations, because you have to have what is called an ulnar variance. Ulnar variance means the distance that the radius and the ulna has. So if the ulna happens to be higher than the radius, it's now called ulna plus or positive variance. If there's a bigger difference than normal, like you should have probably 11 millimeters top in that, or 4 millimeters top in that one. When it increases that number, then you have a negative variance, ulna minus, and those are the terms that you use there. So it's important always to look at those things there. Attachments of specific bone muscles, I'm not going to go through all of them, but it'll be important for you to know, for example, what muscles go into each of the metacarpals, where on the dorsal aspect, how these extensor digitorum tendons go, and for the palmar view, where do they attach the flexors? So you can see that there's a difference for the flexors compared with the extensors, basically for the middle phalanx. Just a close-up for those muscles that get there, and how you're going to see them, and how you're going to be able to understand why they get their names, and also to know what kind of function. So if you're talking about the abductor digiti quinta or the flexor carpi ulnaris that attaches just right there where the part of the pisiform would be, or hamate would be, that's where you're going to be looking at for the digiti quinta or the brevis, or you're talking about the flexor carpi ulnaris. So if they're there, this is the motion, that's why they're called that name. A close-up for the palmar view for the flexor digitorum superficialis or subliminis, and the profundus or deep, where the difference is how they're going to be attaching or inserting into those pieces of bone. A close-up of the dorsal and the interosseous muscles attached to that metacarpal bone. Just a reminder of every joint in this situation as diathrodial type of joints that have a capsule coverage or lining of synovial tissue and synovial fluids because of synovial cells. Understand that on the ulnar side, again, the radial styloid is more distal than the ulnar, but they have to keep a specific distance. Probably 4 to 6 millimeters could be something that could be considered normal. But there's this articular disc. The articular disc, called also the TFFC, the triangular fibro cartilage complex, TFCC. So the triangular fibro cartilage complex is one that can be injured. It's not a true meniscus, but can be injured, and that articular disc attaches from the inner side of the styloid of the ulna into the, sends some fibers to the radius, to the lunate, and basically to the triquetrum. Medially to that, more superficial, is that ulnar collateral ligament. On the radial side, you don't have that articular disc, only you'll have this radial collateral ligament. Between each of the metacarpals, you're going to have an intermetacarpal ligament. Between carpal metacarpal ligaments you're going to have, and you're going to have ligaments from each of the carpal bones. So intercarpal ligaments is the name. There's a recess present between the radius and ulna that also reaches for the joining of the distal end, for this distal joint of the radiocarpal. So the intermetacarpal and intercarpal joints were just mentioned. Think about every single bone has surfaces that are covered by hyaline cartilage. Each of those bones have to connect to, for the triquetrum, to the pisiform, for the lunate, for the hamate. So think about triquetrum, proximal or distal? It's proximal. So proximal is the third, considering from the radial to the ulnar side. So what other bones are connected there? For the pisiform in particular, what part is going to be connected with? The lunate receives its name because when you see it on the lateral view like this, you see it like a semi-moon or M-moon shape. And that's important. The scaphoid receives a name because it resembles a boat, a sailing boat. And you can imagine something like this one more in particular. But they have articular surfaces for each and every bone that's connected to that one. The distal radioulnar joint is with that saciform recess that I told you, it's just to keep good balance at this area, so there will be no friction between these two bones. The articular disc, or the triangular fibrocartilage complex, is the one there. All the other ligaments, just think that they have to be some connection between them. Now, from the scaphoid to the capitate, for example, or lunate to capitate, or the triquetrum to capitate, there's no connection. So probably the capitate, for your reminder, it just goes to the trapezoid and to the hamate. Those are the only two connections. But otherwise, it's going to be directly with the ulnar collateral ligament and the radial collateral ligament for those two rows. And same for the distal row going with the ulnar collateral. But here, basically ends up with the greater multangular, which is the trapezoid, and going into those ligaments between the carpal and the metacarpal.
So just a reminder of reviewing this, all of these muscles, all those ligaments, just read about this part. This is the scaphoid lunate triquetrum, also known the TFCC that I just mentioned to you about. Just apply them adequately for your review of this. The palmar ligaments and dorsal ligaments are the ones that hold the carpal joint or the radiocarpal joint in some way. So you're going to have basically radiocarpal ligaments in yellow here, being there, and you're going to have the ulnar into the carpal for ligaments, and you're going to have this radiocollateral ligament and the ulnar collateral ligament. Those are from the palmar aspect. Those are the ones that are going to be holding the joint itself. Now, from the dorsal aspect, it's going to be the same thing. You're going to be able to have this specific dorsal radiocarpal ligament, but you're also going to have from the ulna as 5, the dorsal, number 6, you're going to have the ulnar collateral ligament, but you're going to have from the radius to the radiocarpal ligament in two bands, as number 5 you can see there, and they connect with specific bands going to the thumb or the first and to the index finger. Just they don't have a name, they just get intercarpal and terephus ligaments. If you want to specify one in particular, you can call it. When there's some dissociation or some injury, that typically the capitate can go this way, ruptures between the scaphoid and lunate, and there's a dissociation of the scaphoid and lunate, and you can Google this, and it's a very typical or a very common type of situation. Besides the TFCC, that this disc can break. So something that tears here and opens here is going to be a kind of a problem in the stability and obviously pain and all the things that go as an acute injury. So you're going to have from one carpal to another carpal bone, you're going to have some ligaments, and you're going to have the collateral ligaments from each one, either a dorsal or palmar one, and there also could be some other name like the radial ligament. But they're connecting from proximal rows, connecting distal row carpal. So the radiocarpal joint can also be injured, and Colles is one of the classification. Smith is another, or reverse Colles is called, but that's a fracture very specific of the distal radius. Typically, you're going to have for the Colles is a dorsal, an extension. With Smith, you have a flexion type of injury. But what's going to happen is that those ligaments are going to be, in a way, hurt. You can have also fracture of the scaphoid, or you have a dislocation of the lunate, or the dissociation between those two bones. Here's a Colles fracture, because you can see the fragment, the distal fragment going dorsally. So this is a dorsal or posterior displacement. You can see the lunate here, how the shape of a half moon is. That's the thumb. This is the rest of the metacarpals. The fracture where the arrows are pointing are the break. This is an extra articular because it doesn't involve the radius and ulna, and there's no fracture going into the radius or carpal. So probably, but you can see here, there's a fracture. There's a classification for this called Frickman, F-R-Y-K-M-A-N, Frickman. And this would be a Frickman 2 because it's extra articular, which is a 1, but if there's a ulnar styloid fracture, that's a pair, a number pair, so that's a number 2. If you happen to have something like this, then this becomes a 3, but with this becomes a 4. If you have here, this line could be a little bit here and this open, then you have a 5 with a 6. But when you have this and this plus this, that's an 8. So just a review of different types of fractures. The other important thing here that I don't see that well is this area. So this looks to be also with an injury of that TFCC complex. What happened here is that they provided this type of surgery, internal fixation. Now, a review for you. What two structures I mentioned from previous class that you're gonna have to be careful with this type of fracture and with this type of technique? And those are the things that are important, because right here you're gonna have the pronator quadratus that you have to remove to place this, and then place this on top of it. And you're gonna have the brachioradialis coming about here, then you also have to lengthen it, because this fragment is going to shorten the tendon. On the other image is an external fixation device. An external fixation device is applied in several conditions where there's a lot of compression or a lot of comminution, and you cannot place a plate. So you have to place something from the outside just to bring some distraction. An example of a fracture of the scaphoid at the waist, you can see the line here. There was placed a screw here just to hold it, and seems that it healed pretty much well. Another important thing, see this, how far? So this is an ulna plus. So there was also probably some injury to the radius, and probably it wasn't really assessed, but see from here to here, there's a difference, there's a distance, and now it grew. So there has to be something else, like I said, from that first fracture, and probably you can see it here, that already you can see that the ulna and the scaphoid are not this, I mean the ulna and the radius, they're not holding a perfect length. There's a lunate dislocation that can be happening too, as you can see here. There's a space between the scaphoid and to the lunate. There's nothing here, there's a capitate, so there's some shift of that proximal row. Complete dislocation, as you can see the lunate here, or a complete dislocation of the wrist for this matter. Okay, let's stop here for a moment, and we'll continue with the muscles insertions at the elbow area and covering the whole forearm for you. Thank you.